Thank you. And I think we need an echo didactic on how you keep track of everybody during the introductions. It's really a work of art. Thanks for everybody for our case. And Amy Lively, my colleague, is on, so she may jump in here since she's known this patient much longer than I have. But our case is a 31-year-old Caucasian male. He has Medicaid health insurance, and he's well known to our program at New River. Hold on, let me minimize my videos there. He was in our program a year ago, which I'll get to all those details in a minute, and then dropped out for about 4 months. Rejoined a little less than 2 months ago, and revealed to us 2 weeks ago that he had been injecting the Suboxone that I had been prescribing in the 2 months that he'd been back in the program. And actually, when I prepared the case form, I focused a lot on his addiction to injecting, but the other issue is also that he admits that he injected the Suboxone because he got a more intense sensation from it. So our questions are both about addiction to injection and also about not using medication as prescribed. So his story, actually, I'm going to take out my earphones and go like that. Can you guys hear me? Can you guys still hear me?
Yes.
Okay, good. So as I said, he started actually in our program in May, I believe, of 2019. Shortly after the program started, he had a history of polysubstance use. He started smoking pot when he was 9 years old. He entered the program with his girlfriend, and they continued to be together as a couple, and came into treatment together, left treatment together, then came back into treatment together this year. When he came in last year, it was for heroin and meth injection use. He got a job at some point. He's a logger, and got a job at some point last year, and had a hard time maintaining the program requirements with respect to medical appointments, behavioral health appointments. And so he decided to drop out, actually, because of his work schedule. And that was in, I think, January of 2020. His girlfriend dropped out at that time as well. But an important point to the story is that they have one child together, and then another child that has a different father, but who lives with them. And those children were taken into CPS custody because the older child reported that he witnessed this father, using a needle in his arm. They came back into the program then in May of this year, which was when I met him. Really, this is the second time I met him, but to take care, to be his prescriber. It was the first time I met him. And since they've both been in the program, they've both denied any relapse and have been doing well, keeping appointments. He struggled a little bit at one point because he went back to working. He lost his job logging in the winter. Then he went back after he had started back into our program, went back to work, and struggled a little bit with keeping his medical appointments, and tried to work something out with us where we would see him on a different day, which just wasn't feasible for us. And so he adjusted his work schedule, and since then has been keeping his medical appointments, which are virtual, keeping his behavioral health appointments are virtual, and has been coming in weekly to give his drug screen. He's denied relapse. All his drug screens have shown bupe only. But then in a conversation with first a behavioral health counselor and then in a medical appointment with me, he admitted to this use of injecting the Suboxone. And at the time that he was talking to me about it, he said he had quit a week and a half or 2 weeks earlier, and that he quit because they were about to have the children returned into their custody, which they have since gotten the children back. And it was a pretty interesting conversation, we thought, because he recognized, that he was taking it not as it was being prescribed, the Suboxone. And then he also said that he was addicted to the needle. I didn't ask if he ever injects anything other than the Suboxone, but anyway, when we talked to him about that being a problem, number one, because he's taking the Suboxone not as prescribed, and then because just using the needle, it puts him at risk for adverse health consequences, he was pretty interested in talking about it. And at one point he said, well, what do you do for it? And I said, I don't know. I'm going to talk to my colleagues on Project ECHO. And our behavioral health consultant has been very interested in this and has suggested using cognitive behavioral therapy if the issue is, especially if the issue is exclusively just addiction to injecting, which is slightly separate than liking to get a more intense experience from the Suboxone. So when we mentioned that to him at his CBT, when we mentioned it at the subsequent visit, he was very interested. So that was pretty gratifying to us that he was open to talking about it and to working on it. Let's see. I think that that's the case. He does, in reviewing the chart for the case, as always happens when I review it for a case presentation for any ECHO session, I find out things that I either didn't know or had forgotten. So I realized that he actually tested Hep C antibody positive last May, although there was no virus detected. So I'll repeat that. It looks as though he may have cleared a Hep C infection. He was seen recently by one of our other primary care providers because in order for them to get the children back in their custody, he apparently has lesions on his arms, which this other primary care provider diagnosed as lipoma, and I believe him. The patient had to get a note for CPS verifying that those weren't related to injection drug use. And the PCP at that time did not see any track marks or abscesses or skin sores. So he really thought that these lumps that the patient has had, he says, for forever, for his adult life, were something different. So our questions, Mitra, maybe if you could go back to the top, have to do with, well, let's see, several things. One would be when somebody really does continue to want to inject, what's the best way to approach that, even if they're not injecting the Suboxone? What's the best treatment for that? Number two, I all of a sudden realized that I never thought about somebody injecting the Suboxone, and I don't ask people if they do that. I don't ask them if they're taking it as directed, although I might start adding that to my questions. But what's a good way to screen for somebody who might not be taking it sublingually? And yeah, anything else that comes up in relation to this?
Thank you so much, Jen. That was excellent. So before we jump into the MAT Hub members' recommendations and everything, does anyone have any questions, comments for Jen and the case?
Was he injecting, was he getting films or the tablets?
Films.
So I want to say something, say some positive things about this case, because a lot of times instead of, I mean, for this patient at least, instead of demanding Subutex or tablets from you, this person was openly talking about his use. So I saw some positive insight over there. So that's why I would say, I appreciate his honesty, and I think there's an angle we can work with. So that's what I think. Another thing is like, we do have, I mean, Laura reminded me, correct me if I'm wrong, but I think we did have a patient like this before. And I think we even talked about Sublocade, right? Sublocade. So in this case, I'm not sure about, I definitely, I feel like Sublocade is the best option, long-acting injectable. But the question is, how can we get it approved? I guess that's that's also something we can discuss. Yeah.
I guess other things I would add is that you could use Vivitrol, so the opiate blocker instead of an agonist. That would be another alternative. And another thing you could do, so if somebody is injecting Suboxone, they're probably not taking it in the schedule, like once a day or twice a day like you recommend. So you might do a pill count and catch him at misusing the Suboxone. And then that might rate, if you called him in for a pill count in the middle of the week and said, look, you're running out early, that's behavior, that's addiction behavior. And then you can intensify his treatment and try to catch some of this addictive behavior.
Which that raises a really interesting point, because I was thinking of this beyond this particular patient. If we did a random count on somebody and they didn't have, I think we usually assume if they are missing it that they're diverting, but I guess they could be using it.
They could be misusing it too.
Right. Yeah. Mm-hmm. Yeah.
So, and I think your point about screening everybody at intake is important too, because that's the time when some people are honest, some people aren't, all along the way. But I always ask, very matter-of-factly, lots of folks come to us taking buprenorphine that they're getting off the street, and I just say, how do you take it? Do you inject it or snort it or take it by mouth? Like, just as a standard question without any. I try and have no particular stigma, but understanding that lots of people use this medication lots of different ways, and it's important for us to understand how you're using it to best treat your addiction. And certainly anybody who has a history of IV drug use, I always ask, have you ever actually injected buprenorphine or Suboxone, and what was your experience? Because some people have and they have a terrible experience, and some people have and they're, they have a problem with taking it as prescribed. And then we know from the get-go, we even say to people, it might be really hard for you to take this medication by mouth and transition from taking it, either snorting it if they're snorting Suboxone as a pill, or Subutex as a pill, or injecting it. And having that conversation from the beginning, if they're able to, now not everybody's going to be honest, can really help us kind of get a better handle on this. And then checking in with them as they enter treatment, how has it been for you to try and not either snort this medication or inject it? Mm-hmm. So, and again, with as little stigma as possible, because they know they're not supposed to do this, and they want to please us, to a certain extent, or they want to, continue to misuse it, whichever it is. And I would kind of frame it as not necessarily catching him, but help him be accountable, because he says he understands that this is not good for him. This is not good to have needles around the kids if they're coming back into the house. We would sometimes go to a daily dosing. If you have the resources, they come in and they take it in front of you. Obviously, that's much easier done at a methadone clinic where they have daily dosing. I wish we could have Sublocade paid for. I know there are lots of studies underway looking at CAM 2038, which is another injectable buprenorphine naloxone combination product, which hopefully Medicaid will pay for. Dr. Bo, I think, has had some success with private insurance paying for the Sublocade. I don't know if any others on the call have gotten Sublocade covered, but that would be the most logical recommendation for him. I just don't know if it's you know, if he will be able to get it covered. I think many patients, this is an issue for many patients, and some people don't talk about it. So if he's willing to talk about it in group, it may get other people talking about it in terms of how do you treat it. First of all, you kind of normalize it. Like this is a problem that lots of people have. That's why we work with people in groups, so they can help each other with how they stopped. But it's also not uncommon to really be to have the whole ritual of use, especially injection use, be difficult to give up. And so the same CBT is a good intervention. So the same kind of treatment applies at, you know, you start with the very beginning, you know, you kind of have to, this may or may not be appropriate in group, it's more appropriate individual to really break down the ritual. What does the ritual start with? Because other patients get triggered by just a description of what the ritual for injection drug use is. And get him to talk about, okay, when you first get that urge to inject, or, you know, when you pick up, you know, the cotton, or, you know, when you're gathering whatever he's doing to sort of initiate the ritual, that's where you need to put a point of intervention. But it helps to know what the exact ritual is, and that's probably better discussed in individual than in the group because it's triggering. But CBT is like any behavior that you're trying not to engage in, you know, CBT is a great tool for the treatment of the injecting piece. So someone put something in the chat.
Separate certification for Sublocade. What does REMs mean?
If you Google Sublocade, it'll tell you like how you can prescribe it. Yeah. You can only prescribe it to like 1 or 2 person per facility without going through that certification process. I forget what the actual letters stand for, but we had a patient that came back from treatment in California that was on Sublocade and wanted to continue it with us, but there's very limited ways to actually prescribe it, what I could find anyway.
Thank you for that.
Just a side note.
And this is a conversation I would like to have with our Medicaid folks here. You know, is there a way to get this medication covered, because it will really help with certain patients who struggle to take medication as prescribed, or don't have a safe place to keep their medication. That's the other thing, that, you know, some patients have their medication taken from them because they're living in environments where, you know, they can't trust the people they're living with.
We also questioned, and it would be more of a question for the prescribers, like, could you combine a Sublocade injection with a Vivitrol injection to have that blocker there as well?
That was my question. Is Sublocade just buprenorphine? It doesn't have
It's just buprenorphine.
Gotcha. But it's long acting.
You couldn't combine it. You'd be giving an antagonist and an agonist at the same time. Because the nature of that, like that'd be like giving someone a long-acting Narcan and then trying to give them Suboxone on top. Gotcha. The thing to keep in mind, had you experienced this before where somebody said they were addicted to the needle? Or is this kind of a new experience for you?
I've heard of it, but I've not treated somebody for it. And I think we have one other person in the program who said he was addicted to the needle. I'm not sure about that. But so for new, really, for me as a prescriber, it's new, even though I'm aware of it.
It really is something. And for those who hadn't heard of it, it is, whether it's the ritual itself or just injecting, but you'll hear people who just inject water or whatever. It's pretty intense at times, but, you know, I was doing a little reading up, but it's kind of like an obsession, like an OCD type thing. So sometimes you can dig down and find somebody has some bad OCD, and that can be treated, of course.
Interesting.
it's just something to keep in mind. So what I often say is if somebody is injecting, like if they say they inject whatever, heroin, fentanyl, I say, I'll flat out ask, do you feel like you have addiction to the needle as well? Like, have you ever just found yourself injecting nothing when you don't have it? And some people just flat out say, yeah. So that can be an interesting conversation. So.
Dr. Morrison, was there something you wanted to say as well?
Yes, I've had this come up many times. So it's not hard to normalize it because it really is quite common. And what I've found is that I have to kind of cut it off right away because everyone starts getting triggered as soon as the person brings it up in the group. So I just immediately interject and try to take over before they can start describing their ritual and get them to like CBT as Laura was suggesting. But what I do when I take over is I suggest, I kind of trash talk the formulation of Suboxone. So I tell them that I think that it's not pH balanced, that I think they put some extra effort into when they were making Suboxone to sort of discourage people from using, that it will really damage your veins much more than other things. And so this particular film to inject it, or even tablets, is going to be much more damaging to your veins. I actually have a case of a person who was injecting it, that it really did just destroy the veins in their legs. So I'll often bring that up and to try to kind of take it away from people getting triggered by it and move towards maybe the first steps of the CBT, where I'm giving them some cognitive reasons to not want to inject.
Interesting. Is it so? And is there a component of it that, even though it has the naloxone in it, is it accurate to say that because they're injecting, they're getting they're getting a little bit of a high from injecting it, aside from the addiction to the needle?
Yeah. So the thing to keep in mind is that the naloxone is more geared towards full opioids. So Suboxone is a partial opioid. So at first, when we heard people were injecting Suboxone like years ago, we thought, no, you can't inject Suboxone. But people do. So it's going to tamper it down. But the thing is, like, I think Suboxone, it's like 30% bioavailability if sublingual. It's practically zero if you ingest it, so you never swallow it. But if you inject anything, it's 100% bioavailability. Even if you're putting some naltrexone or naloxone in there. So they are going to have more like intense feelings. And you'll hear some people ration it too if they're like low on it, just like people went from snorting heroin to injecting heroin because it just makes more financial sense. So some people will do that with Suboxone.
Yeah, I think the other piece to this is that the half-life of naloxone is much shorter than the half-life of buprenorphine.
Gotcha.
And so the naloxone wears off and the buprenorphine kicks in. And so that's kind of what happens when they inject it.
And subjectively, that's what people will describe. It's like at first they don't feel great for a couple of minutes, 5 minutes, but then the Suboxone or the buprenorphine kicks in. So seems to me it's not the most effective way to get high. It seems there are better substances to use if that's what you're looking for. But when I've talked with people about it and they've been honest about the experience, it's like they sort of don't feel great for the first 5 minutes, and then there's a more euphoric effect than taking it by mouth.
Yeah, and I think some of it's financial probably, because if you're getting prescriptions, you can use that, and it's geared towards if somebody's using chronic opioids, heroin or methadone, then it will put them in withdrawal. But if it's recreational, which is what more of our patients are doing, then I think they feel that. So they're willing to tolerate that decreased effectiveness because it's cheaper, it costs nothing to them. So
another thing is the pharmacologically, the ratio of 4:1, 8 milligram to 2 milligrams. So when they designed the medication, naloxone is supposed to be potent enough to block all these receptors. However, people did not use it, really inject it, in those clinical trials or whatever. So I guess I asked my patient before in the past, and yeah, exactly, that's the same thing. People just told me, yes, I could get high. So unfortunately, that's how they felt.
And what they've told me is that when they melt it down, they think the naloxone goes away. Now, I don't know if there's anything to that, but
Yeah, like our patients tell us they put it in cold water first, then melt it down. And when you do that, it actually separates. And then naloxone forms like a little gum ball in the bottom.
Yep.
And you can just, get high off the rest.
That's probably just the binder, honestly, for the films. But everybody's a chemist, so don't forget that.
Right. They're all Walter White.
Yeah, exactly.
Awesome, that was excellent. Any other questions or thoughts before we move into the didactic portion?
I just also wanted to say the fact that he, had a positive antibody test, but does not have active virus, I often use as a motivator. It's like, look, you have had an exposure. Yeah. And so just as evidence of the risk, and you have this opportunity, and I've said this to patients that, like, this opportunity to prevent this from happening, because it's a real thing that could have happened and it didn't. And so, if you want to invoke, if he's into, 12-step recovery and higher power stuff, like, you've been given a second chance. Let's help you take advantage of it kind of talk. And depending on how much he cares about whether or not he gets hepatitis C, that can be, if he's pretty excited that he doesn't have it and doesn't want to get it, that can actually help with motivation.
Yeah, it's a good point. And I haven't had a conversation with him about that yet. It's interesting that I think his disease is so powerful that even having the kids taken from him is one of those things where it's not quite a motivator enough, but maybe his own health. We worry that it's not a motivator enough for him. So that's a great suggestion. Thanks. This has been very helpful.
Awesome. Were there any other questions? Were all your case questions addressed, Jen?
Yep.
All right. Excellent. Thank you, everyone. Laura, anytime you're ready, I'll pull up the didactic for you, and I'll turn things over to you. Just let me know when you'd like the next slide, and I'll advance them for you.
Sure. So this is something we've certainly talked about a lot, right? All of us are seeing many patients who have co-occurring opioid use disorder and methamphetamine use disorder. And for any of you guys who have seen Rick Rawson speak, some of these slides are adapted from some of his talks, because I've seen him speak multiple times, and he just does such a great job that it's hard. And I do have permission to sort of adapt his slides and share them with you. To some of his epidemiological slides are shown here, so you can get in advance. So we'll go over the epidemiology a little bit, the complex clinical presentation that patients have. They have many more comorbidities, including cognitive, physical, and psychosocial problems than your typical individual who presents with opioid use disorder, which makes treatment more difficult. And then we'll go over the evidence-based treatments for stimulant use disorder, including methamphetamines. You can advance it. So there are approximately 40 to 60 million users worldwide, and methamphetamine can come in a powder, a crystal, or tablets. Most common is crystal or powder that our patients talk about, at least in this region. And obviously it can be taken orally, crushed, inhaled, or smoked, or injected. And that also seems to vary regionally. So knowing the route of administration is obviously very important in terms of the comorbidities. So always asking if someone reports at intake that they're using methamphetamines, talking with them about how they most typically use them and if they've ever injected. So people know that actually smoking substances gets it into your system the quickest. And so often those folks have much more rapid progression of the disease process, people who are smoking and injecting than if they're snorting or taking anything orally. Amphetamine itself obviously comes in different forms also. And then the major regions of use are listed there, and we are seeing lots in North America. You can advance it. So there's been a resurgence, and for those of you who've been in the field for a little while, we saw in the early 2000s, methamphetamines being made kind of in people's garages, and there were all these task forces and hazmat teams that would go in and bust people, and buildings would blow up, and it was very dramatic. That's what the Breaking Bad captured some of that. But more recently, and this is really since some of the laws have gone into effect, reducing access to pseudoephedrine, which is what was used kind of in the backyard or the homegrown meth labs. What's happened is the Mexican drug cartels have stepped in to fill the void, and they are producing a much higher potency, cheaper methamphetamine, which is what we see primarily. That's supposed to be 8,000, not whatever that number is supposed to be. It's supposed to be 8,000 per pound, you know, so the potency is higher, and it's very, very cheap. So what we saw when this transition occurred was that patients were saying, I couldn't find opioids, that was their substance of choice, and I could find methamphetamines, is always much cheaper. And that seems to have been how many of our patients who have opioid use disorder have transitioned into having both. You can advance it. This is just a little bit of looking at the overdose deaths, and you can see the solid line is all psychostimulants. The sort of longer dotted line is psychostimulants with synthetic opioids, and then the dotted line is psychostimulants with any opioids, and you can just see the curves surging starting in, you know, about 2012, 2013. And I think this certainly reflects what we've been seeing, both with regard to, you know, what we're treating in our offices, as well as the overdose deaths. You can advance it. So today, the methamphetamines are cheaper and purer. And in 2018, the United States border agents seized 10 to 20 times the amount they did a decade ago. So it's really, what we're seeing is what is happening. And it is somewhat regional. So the West Coast, especially California, has always had a pretty bad methamphetamine problem, and they continue to, but a lot of the other Western states also have a surge in methamphetamines, and then in Appalachia. And so the fentanyl contaminated methamphetamine has also been part of what has caused the rise in overdose deaths. And we've really seen that starting in 2014. You can advance it. So again, these drivers of overdose deaths have been the fentanyl, the analgesics to fentanyl, to heroin to fentanyl. And that has gone up with prescriptions that they've tracked. You can advance it. Yeah, this phase is in, so then we'll see fentanyl next if you hit the, sorry. Yeah. So that, again, you see that dramatic uptick in 2014 with fentanyl. You can advance it. And then the stimulants. So we kind of think about this as a dual epidemic, and I think I sent an article along with this that did you distribute that already, Meetha?
I do have it. I'll make sure to keep it in the recap email.
Okay. So just an article that details this that people can read if they choose to. You can advance this. So in terms of what you guys are seeing, individuals with co-occurring opioid use disorder and stimulant use disorder are just harder to treat. They have more frequent relapses on methamphetamines, usually not on buprenorphine if we're using, not on opioids if we're using buprenorphine, because buprenorphine is really good at treating opioid use disorder. It doesn't really treat, you know, it's not an FDA-approved medication for methamphetamines or stimulant use disorder. And then it's harder to retain patients in treatment who have both opioid use disorder and stimulant use disorder. And then because of the route of administration, as well as the way that methamphetamines act on the body, they can have all kinds of medical problems. And so can be very complicated, especially if they're advanced at all in their use, all kinds of problems. So stroke is a major issue. Obviously, all the IV-related comorbidities are issues, but also pulmonary issues, cardiac issues, and like cardiomyopathy and cardiovascular and cerebrovascular problems are often present. And the patient doesn't know, and the patient doesn't volunteer this information because they're not regularly going to their primary care physician. And so whenever possible, working with people with this dual disorder and making sure we're connecting them to medical care if they'll go can be really important in the recovery. And go to the next slide. And then there's cognitive problems. So, and this is why the treatment has to be different because their brains are really functioning differently. So poor performance on motor tasks, when there have been studies working with people with co-occurring opioid use disorder and methamphetamine use disorder or stimulant use disorder, poor performance in verbal fluency and attention. So sitting in a group for an hour and doing CBT is not necessarily going to be the treatment of choice, at least not exclusively. Poor learning and efficiency and comprehension. So when we're teaching coping skills, they may not be able to process in a regular kind of traditional talk therapy group or even individual therapy. And then poor visual spatial processing, and then slower processing and psychomotor speed in general. So again, when we think about that, that helps us inform, what kind of treatment is actually going to be more effective for people who have these kinds of cognitive problems. And then certainly the behavioral problems, so poor impulse control, disinhibition, which I'm sure everybody has seen in their groups, and then this propensity towards violence, which can be scary. Typically that's when people are under the influence. So I've certainly not experienced that with people who haven't been using, but when people show up to emergency departments or are acutely intoxicated, they're often, they can be violent, which is just scary for providers. You can advance it. And then the co-occurring mental health problems, so higher rates of psychiatric comorbidity. Obviously, psychosis can be induced by the use of methamphetamines. And then when people are trying to discontinue use, they have severe anhedonia. They just feel terrible, which obviously is really a trigger for relapse. Why would I stop using to feel terrible? Most people are not going to be able to stick with that, especially if they're impulsive and have difficulty kind of seeing the long-term benefit. And then poor memory. And then a whole host of complex case management needs. I feel like I wish we had a whole team of case managers who could help people with housing, could help people with, job opportunities and very basic things like people don't have IDs, people don't have their birth certificate to get their ID, people don't have the money to get their birth certificate. I mean, it goes on and on. I was working with a patient today who just felt like there were so many barriers simply to trying to return to a normal life, which again, I cannot deal with in a weekly group when I have 10 other patients in that group. And often they've also burned a lot of bridges because their disease has led them to engage in behaviors that push their social supports away. So they often are very, very isolated. You can advance it. So the craving for stimulants, and people talk about, when people do not have stimulants and they have a stimulant use disorder, they talk about that craving being overwhelmingly powerful. And for opioids, we see that because they feel so sick. And this isn't necessarily because they feel so sick, but because their brains are so depleted of dopamine, because the dopamine surge from stimulants is higher than any other substance. So the craving is often, people just talk about it really being unbearable. And so talk about this in the context of, thinking about it in the context of classical conditioning. So there's the neurobiology of addiction supports that. The idea that craving is automatic and creates a powerful push to use. So it's both physiological. I tell patients it's both physiological and psychological. It's very powerful. And for many, the cravings sort of seem like they cannot have any other choice but to use, because it's not about choice. It can be triggered by external things, people, places, and things, times a day. And this is what we talk about in group. And then it can be triggered by internal stimuli, such as emotional states and mood swings. And managing exposure to triggers and responses is really important. And that's, again, the work of treatment, behavioral interventions, and insight and oriented therapies, as you could see from the list of cognitive problems, would not necessarily be super effective, especially in early treatment. You can advance it. So the early interventions can be key, and often they need to involve medical intervention. So when possible, having someone be in a detox facility can often be helpful, because managing acute psychosis and intoxication, you cannot do this on an outpatient basis because patients are so dysregulated and unpredictable. It's often not safe for them or for other patients. And then managing that withdrawal, to give them some comfort meds to manage that withdrawal can be better done in a detoxification unit, and typically lasts about 2 to 10 days for that acute withdrawal, then followed by treatment on an outpatient basis, or residential and then outpatient. You can advance it. So these are the approved evidence-based treatments for stimulant use disorders: contingency management, community reinforcement approach, CBT, and then other approaches, the matrix model, which Rick Rawson developed and is evidence-based, motivational interviewing, which is not an intervention per se, but it's kind of a style of working with patients. And then increasingly, physical exercise, because it is reinforcing, has shown some promise with people with stimulant use disorder, and then mindfulness meditation. You can advance it. So you guys are probably familiar with contingency management. I don't know if anyone uses it in their, or has integrated it in some way into their current treatment program. We've tried to do it somewhat to get people to adhere to some of the COAT rules, like going to meetings. Some of our groups, we tried to integrate some contingency management, like rewards for coming to treatment, rewards for going to meetings, those kinds of things. But it's basically rewarding people for desired behaviors. And that, the sort of theory in terms of mechanism of action is that gives patients a little boost of dopamine when they get rewarded for engaging in a behavior, and it makes them more likely to do it again. The most common things that people are rewarded for in contingency management programs are drug-free urine samples and attendance. The behaviors have to be really easy to track and measure. So it can't be, participation in group is much harder to do. We tried to do that, and I couldn't handle it because it felt like it could get very subjective. And so it's important to have as objective as possible things that you're tracking and rewarding people for. And also limiting the administrative burden on both the counselor if they're trying to track this during a group, or administrative staff, so that people aren't like, oh, I hate contingency management because it's so much work. We don't want it to be extra work for staff either. You can advance it. So incentives are pretty simple. It's basically behavioral. You do the behavior that we want you to do, you get the incentive, and then the patient feels good. And in a group setting, this is transferable to other patients. They see patients getting rewarded and they want to do that, and so they want to engage in that behavior as well. But this is all basically a behaviorist approach. You can advance it. So the primary principles are frequent monitoring monitoring of the target behavior, providing the incentive as quickly after the target behavior occurs as possible. We know that from dog training, right? You can't like wait and reward the dog. And for patients with methamphetamine use disorder, their brains really need that immediate reward. And then as they get healthier, they can almost tolerate it being extended out. But in the beginning, the reward coming very quickly is pretty important for it to be reinforcing and get connected to the behavior that it's rewarding. And then removing the incentive when the target doesn't occur. So obviously people don't get rewarded if they don't engage in the behavior. You can advance it. So community reinforcement approach is really, to me, feels like a combination of a whole bunch of stuff that we all try and do, but because we have limited resources, we're not that good at doing it. So it typically involves, engaging patients with a therapist, trying to engage family members where that's appropriate, talking about coping skills and relapse prevention skills. You can advance this slide because I think I list them on the next one. Recreational counseling, getting people integrated into community-based activities, whether that's 12-step meetings or going to church or a local softball team, and then job counseling also. So it's much more comprehensive. And the problem is that sometimes we in our settings, we don't have the ability to do all these things. And then a voucher-based program, which is basically the incentives, can be introduced because we know they're effective for stimulant use disorder. You can advance it. CBT, I know I'm running a little low on time, so you guys know what CBT is. Sometimes CBT is not great for individuals in early recovery from stimulant use disorder because they just have trouble paying attention and learning the skills. So while it is an evidence-based treatment, my own experience is it doesn't necessarily hook people, and the incentives really do hook people. You can advance it. The general concepts are encouraging and reinforcing behavior change. And again, if you can integrate incentives into that, that's a good way to do that. Recognizing and avoiding high-risk settings, so that's kind of skills-based training, use of behavioral planning. So that can be very helpful. Often patients, their thoughts are really disorganized. They often haven't been on a schedule for a long time. Teaching them about the benefits of being on a schedule, even handing out planners so people can keep track of their appointments can be a way to do that. And then certainly talking about cravings, coping skills, and with a present focus on behavior and thinking patterns. So Mitra, there have been lots of things in the chat. I'm not sure if we
I
want
was seeing that as well. Did you want me to close off your slide, or did you want to finish that before we go into the questions?
we can save them for the end. I just wanted to make people aware that I am aware that there are chats popping up.
Yeah, absolutely. Definitely take a look at the chats.
Yeah, I'll breeze through these so we get to those at the end. You can advance it. And then the matrix model is a little bit of an older model, but you can download this for free at samhsa.gov. It's a great kind of manualized based treatment, and you don't have to do it all, but you can pick out parts of it if that works for you. And there's even a client companion book. So it's something to take a look at, and it really combines CBT, motivational interviewing, and this positive reinforcement for behavioral change, which are all pieces from the other models that we know works. And the family education groups are super helpful too if you can do any of those. You can advance it. The physical exercise and the mindfulness meditation need a little bit more research, but have shown promise. Again, in part, the physical exercise seems to work because patients get that dopamine release that they're not getting, and it can help with the anhedonia that follows discontinuation of stimulants. You can advance it. I'm not going to go through this, but you guys probably are fairly familiar with motivational interviewing, so you can advance this. And the skills that are non-confrontational, supportive, really reinforcing change talk, helping people come to their destination without feeling forced into it. You can advance it. These are the medications under consideration for the treatment of stimulant use disorder, but there are no FDA-approved medications for the treatment of stimulant use disorder. We sometimes do prescribe Remeron. It's off-label though. There is really, it's kind of amazing. There are no FDA-approved medications for its treatment. And there have been a fair number of studies. So one of the things, I'm involved in the NIDA CTN Clinical Trials Network, and they are actively trying to trying to engage in studies to look at medications that might be helpful, especially medications that are already out there that could be helpful with stimulant use disorder. You can advance it. So just to summarize, in terms of kind of the progression with early acute stimulant use disorder issues, really treating the agitation or withdrawal as indicated, because patients, they can't get through that. They're not going to be able to enter into treatment. Providing evidence-based behavioral interventions, and treat any psychiatric comorbidity, because obviously that will help them feel more comfortable. Often people have significant depression and anxiety or other mood disorders, and then trying to treat medical comorbidities as well, because often people who are especially injecting or smoking methamphetamines also have a lot of dental issues, we know, and so dental pain can be a trigger for relapse and can be pretty intolerable. But my experience is our patients are terrified of dentists, have often had very bad experiences with dentists, so getting their teeth looked at. They also have a lot of guilt and shame, or really shame about how their mouth looks, and so sometimes having those conversations in individual therapy can help people better get motivated to want to see the dentist if that's possible. And then considering medications, if you want to use an off-label medication is a possibility. So the rest are just, I think, reference slides. So anything from the chat, Mithra, that looks like we should address?
Yeah, so we got a lot of great things in the chat. Thank you so much, Laura. That was an excellent didactic. So let's see, we got a question in asking what medications are used for withdrawal. Dr. Morrison, you responded, I like Wellbutrin or Remeron. There's some evidence for TCAs, but I'm hesitant to use them over QT concerns. And you don't do any inpatient, but you've seen much better outcomes when they go inpatient. Thank you for that. Dr. Husted also said for detox, if psychotic, antipsychotics, you can use benzodiazepines sparingly if someone is very anxious, sleep medications for insomnia, for maintenance, Remeron, Wellbutrin. Remeron helps with sleep, appetite, so that can be started in withdrawal. Dr. Morrison, you also said you do give antipsychotics if they show up to outpatient treatments actively psychotic and refuse inpatient. Generally, it's refused. And Sarah, thank you for that chat as well. You've seen amazing results with Remeron. So I apologize, I ran through that really quickly, but before we end the session, I wanted to ask, were there any other thoughts or questions from Laura's didactic or all the great things going on in the chat?
And I just wanted to, can I just clarify, Jeremy, that typically you wouldn't use benzodiazepines outpatient? That would
Not
be
outpatient, inpatient strictly.
Thank you.
We're talking detox. So, yes.
The Remeron, actually, the Remeron study is kind of interesting. It's a small sample size. However, the number need to treat is pretty low. So we're talking about like 1 out of 3 to 4 patients showed response. And the trial, the dose started like at 30 milligram and pushed up to 45 milligrams. So in our on DDU, when I saw patients and I started them with low dose. So whatever effects we see here may not be consistent with with the clinical trial result because we do not start with higher dose, but it's something worth discussion. So it's something also looking backwards, I guess, since Dr. Barry got interested in this medicine, we have a lot of patients in co-clinic using Remeron, and they're really doing, I mean, a lot of patients are really doing well. So they can be advanced to bi-weekly group and a monthly group, even with, we're talking about, you know, dual addiction problems. So it's interesting. Yeah, it's a good medicine, Remeron.
Yeah, and because it's used to treat depression, obviously we know that people who discontinue stimulants are often depressed. So it certainly helps with depression and sleep as well. Sorry, Dr. Hirschler.
Yeah, another interesting thing about medications is that antabuse is effective for cocaine use disorder, but not methamphetamine use. So, and it's the mechanism kind of crosses over, but I'm not sure why that is. Dr. Zhang or Dr. Husted, do you guys know why that is?
I don't know why. I mean, it's the dopaminergic activity of antabuse, but I don't know why it doesn't work for meth. Is a tricky one to pin down. Yeah,
so stimulant use disorder is really hard to treat. I guess that, from my perspective, so I can imagine like when people get up and feel miserable, they try to feel normal every day in the morning. You have a Suboxone medicine like Suboxone can make them feel, you know, better immediately, so they can function well. Then that's, you know, that's effective. They can engage into meaningful life. But we're talking about for methamphetamine, when you admit those patients, they crash, you know, in their room for like 3 days, 5 days. They eat a lot, sleep a lot, then they get up, they go back, they feel normal. They want to feel high. So we're talking about kind of positive enforcement and negative enforcement treatment. So we desperately need a new medicine for that, I think.
Awesome, thanks everyone. So unfortunately we are at the end of our session time. So any thoughts or questions after the fact, as always, just feel free to email me. Thank you so much, Jen, for that excellent case. And thank you, Laura, for that awesome didactic. I'll make sure to attach that article as well in the recap email. So just a few housekeeping announcements to the Hub members. I'm sure you saw all the emails I sent to you, but the one specifically about the judiciary, if you could just quickly take a look at the new dates and let me know if that works out for you guys. The next session is going to be on August 10th, and Douglas Harvey is providing the didactic on Addiction Center of Excellence. And Jeremy Sagan unfortunately couldn't make it to this session, but he also has a case prepared for us for next time. So keep an eye out for that reminder, and we'll see you all next time. Stay safe, and thank you.